Our next speaker will be Dr. Larry Eichenfield. Larry, as you all know, is professor of dermatology and pediatrics at UCSD. So we're on a UCSD theme at the moment. So Larry will be sharing with us his group's work on improving pediatric acne management. Thank you. You're good with this. Yeah.
Thank you, Diane. So I'm discussing a multi-center study of case-based education. I'm also naming this talk Cheesecake Factory and Acne. It's not just because it's a lunchtime meeting, but no conflict of interest. But by background, we know that studies have documented tremendous practice gaps between pediatricians and dermatologists, different styles of practice, and pediatricians not necessarily using state-of-the-art medications for the use of acne. We also know by background that expert management guidelines have been put into the literature. The AARS put together guidelines that were endorsed by the Academy of Pediatrics, and these were published in May of 2013. Dr. Thibodeau actually was a leader of that group. But when you put out guidelines, the question is, does it matter and does it influence care? Now, here's where the Cheesecake Factory comes in, because Atul Gawande, the surgeon and medical writer, had a marvelous article in the New Yorker that discussed implementing change. And what he discussed is how well the Cheesecake Factory does at delivering goods, combining an ability to create a quality product, cost control, but also innovation, because every quarter they come out with menu changes and they push out these changes all over the country on the same day, 1 week of prep, the chef's practice, and then the new menu items are there. And he pointed out that medicine doesn't do as well in terms of trying to get delivery of innovation and change. We actually do it pretty miserably. And he explored the methodology of what can you do to get people to do things in a better way and more consistent way. And so now we come to acne. By background, and in the US, if you look at how guidelines are disseminated, the data is terrible. So for instance, the use of beta blockers after a heart attack was shown to have statistically significant impact on mortality, and yet 15 years after guidelines came out to recommend this, only 50% of healthcare of individuals had this advice from their doctors. So we generally do tremendously badly at pushing through changes even with the guidelines process. So we know that there are gaps in terms of the practice in acne, and this has been documented in the literature, both for pre-adolescents and adolescents. It's known that topical retinoids are underutilized by pediatricians. In pre-adolescents, pediatricians are likely to prescribe oral antibiotics, including oral clindamycin, without a topical regimen. There's a frequent use of topical antibiotics without benzoyl peroxide. So trying to close the gaps, if you look at the literature, what's the best way to get people to manage changes? And one of the strongest methodologies is case-based education, because doctors tend to think in terms of patients and cases, and that's a way to drive through change. So our hypothesis was actually that if we did it case-based education, we could drive change in acne management amongst pediatricians. So we had 150 participants that were recruited at 4 pediatric conferences. Patients had to be either board-certified pediatricians, FPs, pediatric PANPs, or ACGME certified pediatric residents. And we did a baseline assessment of their knowledge of the guidelines and their confidence in prescribing according to the expert recommendations. And then we had 5 cases that were presented. I'll show you in a second what they were. And they had to put how they would manage those particular patients. That was baseline. We had an educational intervention. Then it was the query was repeated, and then 1 month and 3 months afterwards, they were given essentially a repeat of those cases. The presentation was 40 minutes from beginning to end, so it was a fairly short algorithmic-based presentation that stressed the algorithm of care, and it ended with repeat query for responses. And the cases basically had a case of mild acne in a teenager, mild acne in a pre-teenager, moderate acne in a teenager, and severe acne in a teenager. And the cases were designed and modified and tested prior to our going out on the road to do these conferences. Now, in this methodology, what we wanted, so we had a case of moderate acne in a teenager, we scored responses as either correct or not correct, and the definition of correct was it would fit within the algorithm of the AARS guidelines. So one could argue whether that's correct or not, but at least the whole purpose was to see whether we could get them to prescribe as per the expert recommendation methodology. And then we did a formal analysis of the differences after the intervention by questionnaire at 1 month and 3 months using McNamara test for the matched categorical variables. And for the self-rated guideline knowledge, that was just done with a simple t-test. So we had 150 providers who participated. 80% were pediatricians, 9% were pediatric residents, and a smattering of others. 41% completed the final survey. This was a mix of suburban and urban practitioners. They represented a diversity of practice types, both in terms of pediatric group practices and academic centers, as well as private practice or multi-specialty groups. This group was actually a pretty senior group, which I'm actually pleased because they're people who've already established their practice patterns. So there were about 70% of them who were out at least 10 years in pediatric practice. The 0 to 5 years were mostly the residents. So their baseline knowledge, they were asked to relate their knowledge of the guidelines to start. And their self-rated knowledge of the guidelines was poor. So the fair and poor, about half of them had fair or poor knowledge of the self-rated knowledge of the acne recommendations. And post-intervention, the vast majority of them had good to excellent knowledge because, of course, they had gone through an educational intervention, but remembered that they did. And then the self-rated confidence in using the acne recommendations markedly improved. It was rather poor at the beginning. And so, from a standard number, pre-intervention, post-intervention, there was a markedly statistically significant improvement in their confidence in being to prescribe according to the recommendations. Now, the actual questions, the responses to the cases, 70% of the responses were correct at the beginning. That increased to 86% at the 3-month time period. Statistically significant different. Their initial errors were very similar to what had been documented previously, underutilization of topical retinoids, use of oral antibiotics without topical retinoids, also checking off that they would refer a patient for isotretinoin without initiating oral antibiotics prior to that. And the most significant improvements we saw actually were in the moderate acne category, where especially for facial and truncal acne, where there was an increased use of retinoids and benzoyl peroxide. This is just the sort of raw scores of the percentage of patients. So all I want you to take away from that is that in the moderate acne category, there was a lot of what we say is subpar prescription of products at the initiation of the study, with marked improvement afterwards. Now, not all the practice gaps were filled. There was a persisting reluctance to use topical retinoids in pre-adolescence. It has not been many years that we've had products that were approved under age 12 for use of acne, and there was a lack of initiating oral combination therapies in patients with severe acne. The limitations in the study, we only had about a 40% response in the follow-up surveys. We did not study the actual prescriptions that these doctors wrote in their practices. This was all in response to a survey of a hypothetical case, and there was a limited sample size. So implementing guidelines is clearly a process. I think that case-based education has been shown in other intervention trials to be a way to drive change, and I think that this showed utility in the group that went through it in terms of both adopting knowledge of the guidelines and using it in their practice. It would be very interesting to implement similar programs more broadly to improve acne management. Thank you.
Thank you. Thank you. Thanks, Are there questions for Dr. Eichenfield?
Okay.
I have a question. Oh, come back.
Okay. Yeah.
I think this is fascinating. I'm impressed with the improvement over time. Had you given any thought, or what would be your thought about having such a module that could be accessed online on a website and just made available? What would you think about that?
No, I think that this would be as effective online if you could get people to it. So I think that there's some focused for pediatric residents, for instance, where you can sort of really direct them to such training would be useful. But there's no question that you'd want broad implementation. What I was pleased with is that we had a lot of senior doctors, 10 to 20 years into practice, and they're very interested. Pediatricians are very, very interested in learning about acne because they see it all the time, they just haven't been trained. And as Dr. Thibodeau knows, before we did the Pediatric Acne Guidelines, what the Academy of Pediatrics had available was tremendously outdated. There was only a single retinoid that was listed. It was just really so they haven't kept up with it. But I do think that the hard thing is, how do you drive the information? If I put something up on a website, I wouldn't necessarily get people to it. And maybe it would be appropriate, there could be partnerships, whether it be the Academy of Pediatrics or industry, or some way to sort of drive people to educational sessions, because I think it could really improve acne care. And most importantly, that will translate to improved treatment of our patients.
I think we have a question, Jocelyn.
Just a comment that actually the AAD sponsors something called the Basic Dermatology Curriculum, which was initially built for medical students, but is being retooled for family practice and internal medicine. And actually, there were a number of modules just built in association with the Society for Pediatric Derm. So that is an online resource. Right now, it lives on the AAD website, but I think a lot of people are making an effort to let our colleagues in other fields know about it.
Thank you.
Great. All right. Thank you.